Hello?
Make sure, can you hear me?
Yes po.
Okay, sige. I'll start screen share.
Okay po.
Can you see?
Yes po, Doc.
Okay, so our topic for today is fetal growth disorders. You will get, I was asked to give 20 points from this lecture. Okay, so let's start. Human fetal growth composed of your three phases: growth, differentiation, and maturation. So there is a sequential pattern of tissue and organ growth, differentiation, and maturation. So this one. Okay. However, there is that we call obstetrical dilemma wherein humans need to walk upright, meaning having a narrow pelvis, and the need to think, having a large brain, therefore a large head. So the fetal head must be able to negotiate with a narrow pelvis for us to survive for reproduction. So for a normal delivery as well. So what are the factors? Sorry. We have the fetal growth phases. We have three phases. The first one is the first phase, which occurs during the first 16 weeks of age of gestation, wherein there is rapid increase in cell. Per day, there is an expected 5 grams of increment in the birth weight or in the fetal weight. For the second phase, it's composed of cellular hyperplasia and hypertrophy, and it's from 17th week to 32 weeks age of gestation. So the expected growth at this time is 15 to 20 grams per day. And the last week, which is mostly cellular hypertrophy, it occurs at 32 weeks and beyond. And this there is accumulation of fetal fat and glycogen. This is also the phase of maximal fetal growth. No, it's a maximal increase in the fetal birth weight or fetal weight, wherein there is 30 to 35 grams per day expected increase. So what are the factors that determine fetal development? So we have the three factors: maternal formation of substrate, placental transfer of this substrate, and the presence of insulin and insulin-like growth factors. So there is a positive correlation wherein an increase in the maternal provision, increase in placental transfer, increase in the presence of insulin and insulin-like growth factors equate to more fetal growth development. However, your growth potential is governed by the genome. So this is exemplified by babies of the Caucasian race have likely higher birth weight compared to us. Estimated birth weight, normal birth weight is around 3.5 kilos, whereas for Asians, the estimated normal birth is around 2.5 to 3 kilos only. So what are the factors that affect fetal overgrowth? So we go to fetal overgrowth. Fetal overgrowth happens when there is excessive transfer of lipids, excessive glycemia, fetal hyperinsulinemia, overexposed endothelial lipase, overexpressed. There's greater intake of certain fatty acids, particularly particularly omega-3, and higher free fatty acids during the later half of the pregnancy. Whereas for fetal growth restriction, there's reduced modulation of rapamycin complex. The rapamycin complex is the one responsible for the transfer of amino acids, less transfer of lipids, and reduced endothelial lipase. So it still goes to show that it's still consistent with the higher the availability, the higher the probability of fetal growth. So in this case, the lower the ability of the nutrients, the higher probability that there is fetal growth restriction. So what is a reference for a normal birth rate? A normal birth rate is different from ecaucation versus stagnation, as I have told you a while ago. So it should be a popular reference, and a normal birth weight is not standard for all races. And it should be dependent on the population. So instead of using the standard reference, which incorporates normal pregnancies with normal outcomes, we use the popular reference. This incorporates pregnancies of varying risks along with the resulting outcomes, both abnormal and normal. So what's the implication? For us, Asians, as many as 70% of small for gestational age, SGA is small for gestational age infants, have actually normal outcomes. So they are thought to be appropriately grown when maternal ethnic group, parity, weight, and height are considered. As opposed to standard reference wherein these SJA infants are actually at. So if you use the standard reference, these 70% are SJA infants. But when you use the popular population reference, these 70% of SJA infants are actually belonging to the normal birth rate. So that's the difference. That is why we are using the population reference. So this is the expected fetal growth in comparison or in contrast to the gestational age. It is compatible with the one that I showed you a while ago in the three phases. Okay. So birth weight, we cannot use birth weight as a measure to define fetal growth because birth weight is already the outcome. Whereas the fetal growth rate is the rate by which if there is increase in the weight, the rate in which there is increase in weight for a certain period of time. This is estimated by serial sonography, the fetal growth rate, whereas in the birth weight, it is taken during the baby's birth. Okay. So is it important to differentiate? This is applicable for determining which babies are having intrauterine growth restriction for proper management. So diminished growth velocity may be linked to perinatal morbidity and adverse postnatal metabolic changes that are independent of the birth weight. One concrete example would be an estimated normal birth weight for 37-weeker is 2.25 kilograms. But if the baby at 34 weeks is already 2 kilos, after 2 weeks is still 2 kilos, that is abnormal fetal growth. But the baby can reach a birth weight of 2.25 after 4 weeks from a 2 kilogram baseline at 32 weeks. The baby may have a normal birth weight, but the fetal growth was already stunted. So that's the difference. So the formal definition is that these are low birth weight newborns who are small for gestational age and are often designated as having fetal growth restriction. Your SGA or small for gestational age babies are neonates whose weights were below the 10th percentile for their gestational age. So we have two types of growth restriction, the asymmetric and symmetric growth restriction. For the symmetric growth restriction, the babies are proportionally small. The fetus are proportionately small, and it has the insult most likely occurred early in the age of gestation. For the asymmetric growth restriction, there is disproportionate lagging of abdominal growth compared to head growth. The insult follows a later pregnancy. In this variation, the resultant diminished glucose transfer and hepatic storage will primarily affect the cell size and not the number. Therefore, fetal abdominal circumference would be greatly reduced. And this is also part of the survival mechanism as we need a large head. So we concentrate, or the baby's body concentrate all the nutrients in the brain. Therefore, there is an asymmetric growth restriction. Okay. So to better visualize, you have your normal growth. You have a normal head and a normal abdomen versus the symmetrical fetal growth restriction and then your asymmetrical fetal growth restriction. We have in intrauterine growth restriction, there is a certain pattern or event that we obstetricians are aware should be wary of. Then this is the brain sparing. Brain sparing occurs when there is preferential shunting of oxygen and nutrients to the brain. This allows normal brain and head growth. This also results from asymmetrical features thought to be which thought to preferentially protect from the full effects of growth restriction. Your placental abnormalities, one of the major causes of fetal growth restriction and is associated with early defects in placentation. You have your implantation site disorders that may both be a cause and a consequence of hypoperfusion at the placenta site. This is also, despite aside from a gross abnormality in the placenta, the mechanism of the placentation itself, which occurs in preeclampsia patients, causes causes growth restriction in affected individuals. So, is there a need to determine if there is growth restriction? Because of the perinatal morbidity and mortality, patients, babies, or fetuses that are growth restricted have increased rates of stillbirth. They are also are at risk for increased adverse neonatal outcomes, which are birth asphyxia, meconium aspiration, hypoglycemia, and hypothermia. So in these patients, in um, suspected patients or known fetus that are growth restricted, you should be notifying your pediatrician of this problem so that they are able to prepare beforehand prior to the delivery for proper resuscitation. Okay. These are the risk factors and etiologies for fetal growth restriction. Actually, the three are also applicable to fetal overgrowth, just the opposite. So if there's poor gestational weight gain for intrauterine restriction, for fetal overgrowth, there is excessive gestational weight gain, something like that. So for the women who are constitutionally small also have fetally growth restricted fetus. Women with poor nutrition, social deprivation, and eating disorders would most likely have a fetus that is also growth restricted. Some fetal malformations can cause fetal growth restriction. So Maternal medical conditions like hypertension, chronic diabetes also causes fetal growth restriction. Chronic diabetes mellitus. Your gestational diabetes mellitus is the one that is responsible for fetal overgrowth. But in chronic diabetes mellitus patients, the baby are more likely to have fetal malformations and fetal growth restriction. So that's the difference. Certain genetic abnormalities also causes fetal growth restrictions. And of course, multi-fetal gestation because of the concept of space will also result to fetal growth restriction. Again, placental or cord abnormalities can also, because of the decreased supply of nutrients, will also cause fetal growth restriction. Okay, so this is summary of what of your Venn diagram here. Okay. There. So these are the factors that affects or that causes or leads to intrauterine growth restriction. What about multi-fetal gestation? So pregnancies with two or more fetuses is more likely to be complicated by diminished growth of one or more fetus. That's why multi-fetal gestation are considered high-risk pregnancies. So look at the chart. Compared to multi-fetal gestations, compared to singletons, multi-fetal gestations have a lower birth weight and stunted fetal growth. Okay. What about teratogenic drugs? Mostly teratogenic drugs that affect fetal growth restriction are your anticonvulsants and antineoplastic agents. What about coffee? Can coffee cause fetal growth restriction? What about smoking, alcohol, and caffeine? So your coffee or the intake of coffee does not cause fetal growth restriction. But smoking, alcohol, and cooking does that does cause fetal growth restriction. As for prednisone, there is a possibility, but um, this one is most likely associated with the underlying medical condition. Prednisone per se or prednisone on its own cannot cause fetal growth restriction. But in conjunction or in relation to the medical condition that caused the mother to take that medicine, that is the most probable cause for the fetal growth restriction and not the pregnancy. What are the chromosomal abnormalities that causes fetal growth restriction? Your trisomy 21 only causes mild growth restriction, whereas the Turner syndrome or the 45XO and the trisomy 18 causes poor fetal growth. So, those said, how will you recognize fetal growth restriction? Early establishment of gestational age, ascertain of maternal weight gain, careful measurement of the uterine fundal growth throughout the pregnancy will identify many cases of abnormal fetal growth in low-risk women. So for low-risk women, establishment of gestational age, determination of maternal weight gain, and the measurement of uterine fundal growth, every follow-up will suffice. This one is applicable especially for midwives. This one is okay and has good predictability, even if done by midwives, because these are repeatable values. Although examination frequency varies depending on the indication, and initial dating, especially for patients who are unsure of their menses, an initial early dating examination followed by an examination at 32 to 34 weeks or when otherwise indicated will identify many growth restricted fetuses. Target population here would be your teenage mothers. Number one, they are prone to dieting, and well, they are also the ones that do not remember their last menstrual period. However, despite that, identification of inappropriately growing fetus remains a challenge, especially in our country because not all women are what's this educated or taught or something of that effect. Not all are aware of their normal menstruation. Even their last menstrual period, it's so hard to ask to get from them. Okay, so what can we do? So one, and the easiest would be your uterine fundal height. So what are our landmarks? The symphysis pubis and the uterine fundus. So this should be taken in centimeters. Centimeter. So your uterine fundic height or fundal height is correlates to your age of gestation during 20 to 32 weeks age of gestation. So aside from this, our next step would now is to do sonographic assessment. The earlier, the better. The sonographic assessment in low-risk patients are usually done at 16 to 20 weeks age of gestation. Earlier in high-risk pregnancies. So first trimester examination is added to establish gestational age and identify anomalies. These are also the times that if the mother is high risk for if the baby has high risk for congenital anomalies. Depending on the risk factors of the mother, then this is also the time that congenital anomalies are identified. Some would then recommend repeat sonographic evaluation at 32 to 34 weeks to evaluate fetal growth. Although first trimester sonography has limited accuracy to predict small for gestational age newborns, it is important because it closely estimates age of gestation. It also has the most accurate estimate of age of gestation. What about amniotic fluid assessment? There is an association between pathological fetal growth restriction and oligohydramnios that has been recognized. A decreased amniotic fluid volume between 24 and 34 weeks, age of gestation was significantly associated with malformations. In the absence of malformations, a birth weight less than the third percentile was seen in 37% of pregnancies with oligohydramnios. 21% with borderline amniotic fluid volume and only for 4% with normal volumes. So if the baby has a severe oligohydramnios, then think also of a possible intrauterine growth restriction. What else? In small for gestational age babies, wherein you have no other risk factors. For in mothers that have medical conditions, a Doppler velocimetry or Doppler studies is warranted. So this is based on the early changes in placental-based growth restriction that are detected in the peripheral vessels. Mostly studied are the umbilical and middle cerebral arteries. Late changes are characterized by abnormal flow in the ductus venosus and fetal aortic and pulmonary outflow tracts, and by reversal of the umbilical artery flow. Abnormal umbilical artery Doppler velocimetry findings, these are absent or reversed and diastolic flow, have been uniquely linked with fetal growth restriction. And especially with reverse and diastolic flow, if not managed immediately, it can cause fetal death in utero. So how can we prevent? Fetal growth restriction prevention is ideally begins before conception. So these are the 3 months prior that mother should take folic acid, mother should stop smoking, the likes. Maternal medical condition, medications, and nutrition are optimized, and smoking cessation is critical. Other risk factors that are tailored to maternal condition, such as anti-malarial prophylaxis for living in the endemic areas and correction of nutritional deficiencies. Especially in our country, we have to supplement iron. It's a very prominent disease in our women, iron deficiency anemia. Of note, treatment of mild to moderate hypertension does not reduce the incidence of growth-restricted newborns. So this is an algorithm in the management of the fetal growth restriction. So if there's suspected fetal growth restriction less than 38 weeks in babies that are less than 24 weeks, of course, in this case, you already know that we have at least an accurate estimate of the age of gestation. For less than 30, for less than 24 weeks, if maternal status indicates maternal BP of 200 over 100, then deliver. Otherwise, if the mother is stable, you may give supplements to increase the weight gain and to repeat sonography every 3 to 4 weeks. In 24 to 34 weeks, always evaluate maternal status and comorbidity. So this also is the time where you request for Doppler velocimetry, fetal testing if necessary, and consider corticosteroids for maturation of the lungs. In presence of reverse and diastolic flow, non-reassuring fetal tracing, and indications for delivery, then deliver. If no indications, we give supplements and repeat sonography for fetal growth every 3 to 4 weeks. In babies that are 34 to 38 weeks old or age of gestation, again, evaluate maternal status. So take note, the common factors here are evaluate maternal status and comorbidities, Doppler velocimetry, and fetal testing or fetal well-being studies. So in say fetal well-being studies, these are your NST and your PPP. In presence of absent or reversed and diastolic flow, oligohydramnios, non-reassuring fetal tracing, and deteriorating maternal status, then deliver. If no indication for immediate delivery, we may repeat accordingly. Okay. American College of Obstetricians and Gynecologists recommends that pregnancy is complicated by fetal growth restriction at risk for pulmonary maturation before 34 weeks. Antepartum fetal surveillance, meaning periodic weekly Doppler studies of the umbilical artery, sonographic assessment of fetal growth every 3 to 4 weeks, and fetal heart rate tracing are your NST. So that's for your fetal growth restriction. We proceed to fetal growth. Fetal growth comprises infants exceeding the 90th percentile for a given gestational week and are usually used as a threshold for macrosomia or large for gestational age. These more probably are the newborns who weigh 4,500 grams or more at birth. So this is shamelessly copied from Williams, and our basis is more than 90th percentile. What are the risk factors? Well, as I have shown you, flashed in the previous slides, we have the maternal, placental, fetal factors, and genetic factors. So, an increase in the increase in the nutrients, increased supply of nutrients, will lead to fetal overgrowth. So these are the factors. One would be obesity, diabetes, gestational and type 2 diabetes, post-term gestation, multiparity, Of course, large size of parents, advancing maternal age, previous macrosomic infant, and racial and ethnic factors. Like in fetal growth restriction, we also have to diagnose or recognize fetal overgrowth because of the complications. Unlike in the fetal growth restriction, it affects mostly the fetus. In fetal overgrowth, the maternal health is also compromised because of postpartum hemorrhage, of course, perineal resolution, especially in macrosomic patients, and maternal infection in prolonged labor. Wait, yes, and because of prolonged labor due to fetal overgrowth. For the neonate, dystocia is a complication. Traumatic delivery. So babies would end up with fractures. And worst case scenario is fetal death during delivery. So diagnosis is important, and this can be done by identification of risk factors in the mother, especially using a index of suspicion. If you have a fundic height above 33 centimeters, this applies for Asian. A fundic height of 30 centimeters, um, a diabetic with uncontrolled sugar mother, and more objective would be a sonographic measurement of the fetal size. What is the management? For large babies, we can do prophylactic liver induction. All of this, you have to talk with your patient. So ideally, the mother has a good follow-up. So this is where a good follow-up comes in. Because when you detect a fetal overgrowth, you can discuss with the patient possible outcomes and possible different management. They would have a proper time to prepare and to choose which one they would like. So for fetal overgrowth, we can do prophylactic labor induction. Some clinicians have proposed labor induction when fetal microsomia is suspected in non-diabetic women to obviate further fetal growth and thereby reduce potential delivery complications. Theoretically, it reduces the risk of shoulder dystocia and cesarean delivery. However, current evidence does not support a policy for early labor induction. So, in short, if you are to do prophylactic labor induction, the baby or the pregnancy should be at 39 weeks age of gestation or more. Moreover, delivery or induction for suspected macrosomia at term is likewise not indicated. Because if there is suspicion for macrosomia, then an elective cesarean delivery may be offered. The American College of Obstetricians and Gynecologists does not recommend routine cesarean delivery in women without diabetes when the estimated fetal weight is 5,000 grams. So, a macrosomia in Caucasians is defined as fetus with an estimated fetal weight of 5 kilograms in non-diabetic women. But in non-diabetic women, the cutoff is 4,500, smaller. This is enlarged because of the preferential storage in the shoulder of preferential storage of the extra fat in the shoulder pad area, which makes the babies or fetuses of diabetic mother susceptible to shoulder dystocia. Okay, that's my last slide. Any questions? When is your exam for this?
December 4 po.
Next week.
Yes po.
I believe you're the class that has an exam later.
Yes po, 10 a.m.
Okay. You have 1 more hour to review. Who is responsible in taking note of the attendance?
I think po
The college already.
copy na.
Tama?
Yes po.
Yes? Okay. Sige. Hana, yung request ko
Yes po.
to remind me.
Sige.
Okay, I'll end. This concludes our lecture. Study well for your exam later.
Thank you.
Bye-bye.